Good afternoon, everyone. Welcome to episode 26 of the Beyond Cancer series. My name is Gail, aka Sunshine, and I will be talking to two oncologists today. Before we get started, just in case you haven't heard of Epic or maybe somebody told you about this episode, Epic Experience was started in 2012 by Nancy Farrow after her oldest son, Michael, was diagnosed with testicular cancer and then kind of had a hard time getting his life back on track. So since that time, since 2012, we have hosted over 500 campers at our signature week-long programs. Those have been put on hold momentarily because of COVID, but we've pivoted to have virtual camps. Other programs such as the Beyond Cancer series is now happening more frequently. So there's been a lot of other things going on instead. So I'm part of the alumni team, and we're the ones who kind of put together the series just to kind of put topics out there that cancer survivors and their family and friends might be interested in learning about. Our whole goal is to help people, survivors and thrivers, live beyond cancer. So to that end, today we're talking to two oncologists, Dr. Paul Maroni and Dr. Mike Glode. And we're going to be talking to them about their specialties, about oncology in general, and some other topics like that. And as we get going, if you have comments, go ahead and put them in the comments feed and we will post those. Until they come, I will tell you my story. I attended an Epic camp back in 2016. I didn't think I needed a camp, but I needed it more than I could have imagined. I needed to just play and laugh and be with other survivors. I was one of those who kind of, after I got through my second time through, I kind of put it behind me and I figured I'm done with cancer. And I really already thought I was living beyond cancer. And then I attended an Epic camp and I realized I really hadn't been. There were a lot of things that I had still been kind of stuffing or denying or not dealing with, and attending the camp was life-changing in so many ways. So now I am on the alumni team, as I mentioned, and I am the in-house editor/writer of all marketing and communication type things, except for social media. We have someone else who is fabulous at all the social media stuff. She takes care of that. But that's kind of how I got involved, and here I am, the impromptu, I guess, or de facto interviewer on this Beyond Cancer series. One fun fact about both of these oncologists is that they have both volunteered at Epic, and so I'm hoping that once they join us, they will tell you about it. So here we have Dr. Moroney. Welcome.
Hey, Sunshine. I didn't tell you my camp name.
Oh, what is it?
Pretty sure I was Doogie when I was
Doogie.
there,
I've heard of you. Yes, yeah. Doogie as in Hauser, right?
Mm-hmm.
Awesome. Love it. Yes, I was given the name Sunshine actually by another camper who has since passed away. So it's even more meaningful for me because she gave it to me. So, well, why don't we jump in? And if Dr. Glode joins us, he'll join us. How's that?
That sounds great.
Okay. If you don't mind, why don't you start by telling us a little bit about yourself, where you live, I don't know, a fun fact, a hobby, anything along those lines.
Well, I'm a urologic oncologist in Denver. I've been here for 20 years now. I grew up in Illinois, and I primarily specialize in diseases of the prostate. I did my fellowship in Indiana, and Indiana for younger men is kind of well known as it's really the birthplace of the chemotherapy for testicular cancer.
Really?
So I was pretty lucky. I got to meet Dr. Einhorn was the guy that developed it, and I was lucky enough to meet him. I'm not sure if he's retired now, but I think he was even in his 80s when I was a fellow there, and that would have been back in the 2006, 2007 time period. Hey, Mike, how's it going?
Dr. Glode, thank you for joining us.
Thanks. I don't get what the technology is about, because there was on my calendar, there was a thing that had Google Meets, and then the next thing was something else. And now here I am with this one, which said it won't work with Safari. So I had to open Chrome. Why doesn't everybody just use Zoom? It works every time.
It's true. Well, we're here.
Yeah.
So we just got started, and Dr. Moroney was just kind of doing a little introduction. You said Indiana, and go ahead, was there more?
Yeah, well, and I don't know, fun fact is if I wasn't a physician and surgeon, I'd probably try to be a surf instructor, even though I've never gone surfing before.
Oh, I was just about to ask you all the different places you've gone surfing. Well, where would be your first place then? If you were to go surfing, if you were to be this surf instructor, where would you go?
Oh boy, I don't know. I'd probably try to, go North Shore in Hawaii or someplace like that, someplace big.
Awesome. Well, my next question I'll just ask you right now. How many times have you volunteered at an EPIC camp? I know your name is Doogie. I now know that.
I've been there. I was there once, and I can't remember the year that I went. I would say probably 2014 or 2015 was the year, the time I served. I do remember it was in October because it snowed. There was snow on the ground one of the mornings, but it was
Wow.
otherwise beautiful out there.
And and that would be one of my next question is what was like a real impactful part of that, or what did you learn, or what did you take away from your week at the camp?
Oh boy, it's just an unbelievable, serene place to spend time. The solitude, but also or the opportunity, I guess, for solitude and relaxation, but then also to have like-minded people around you, a focus on wellness, eating healthy meals, and getting, going on walks and, petting the horses, and then, the friendliness of the instructors for the kayaking and the rafting. It's just the Pharaohs, the job that they've done in building an unbelievable camp for cancer survivors. I can't give them enough credit for being able to do that.
Yeah, thank you. Well, Dr. Glode, we're just starting off with kind of some introductions. So if you don't mind, just tell us where you live, hobbies, fun facts, anything you want to let us know about yourself before we get started.
Fun fact is that I'm really an old guy, and Dr. Moroney is my doctor. So let's see. I live in the suburbs west of Denver in Genesee, and I don't know. I moved here. I grew up in Nebraska and went to the University of Nebraska for 3 years actually. Met my wife there. We went to medical school together at WashU in St. Louis, and then traveled around. I was in Dallas for a couple of years, NIH for a couple of years in Bethesda, Maryland, and Boston for a couple of years, and then came here about, it's been 42 years ago.
Wow.
Right? Something like that. 1978. Anyway,
awesome.
And spent my whole career at the medical school. Ended up, I was a medical oncologist there. And when I first got there, there were only two of us. There was the division head, who was a hematologist, and myself. And I was the only one who had boards in oncology, actually, at the school for the first few years. And then it grew like crazy, and it became a major cancer center. And as we developed more and more faculty, people sort of split up the responsibilities for different cancer types. And I ended up with the GU program that Paul's part of and probably now runs, for all I know. There's the surgeons like Paul are into titles. So if you look when they send an email, they're the director of this and the associate director of that and all of that sort of stuff. But anyway, Paul and I worked together for 20 years or so. Is that about right, Paul?
I started in 2000, but mostly the last 15.
Yeah. Anyway, and we took care of patients together, and then Paul got me involved with the EPIC program, and I've volunteered probably half a dozen times, something like that. And I sort of share what Paul said. It's a great experience, and all kind of done with the energy of the Farrow family. And
right.
I think patients really have benefited from it, and it's been an interesting experience for me as well.
Awesome. Well, then I must ask, what is your camp name?
Doc Holliday.
Doc Holliday. Awesome. And what in your camp experiences, what would be one I don't know, memorable experience, takeaway, lesson from any of the times that you've volunteered?
Well, I think that the most meaningful part for me is the small groups when when people are really able to let their hair down and talk about their experiences.
Yeah.
And that's always been very helpful. For the fun part for me was when we did hard shell kayaks. It was always challenging and a little bit scary. And I've been in a hard shell kayak, so it was really a great experience. But now that they're using the duckies, it's a little less intimidating and probably a little safer for a lot of us old people. But
yeah, true.
It's all fun and getting away up there for a week and just everybody getting along and having a good experience has been really fun.
Awesome. All right. Well, we have a series of questions on different topics, general oncology questions, robotics, and then we have some on bladder cancer and on prostate cancer. So we'll just kind of see what we can do. So I'm curious how both of you got into oncology in general, and then how you kind of got into your specialty that each of you have chosen. And you can I can either have call on you, or you can just take turns and be nice, however you do it.
Paul can go first.
Well, so in urology, you start out, why did I want to do urology specifically in the first place? I liked surgery, and I liked surgery of the pelvis. But to be honest with you, I didn't want to be a middle of the night surgeon. And I sort of thought the general surgeons were, they'd have a lot of call and trauma, and they would be working in the middle of the night. I later learned that that's not entirely the way it is, but when you're a med student, that's kind of what you think. And so urology seemed like a good fit. I remember the first operation that I saw, there was sort of this temple of doom moment where the urologist kind of like swam his hand around in the pelvis, and then he kind of came out clutching this lump of flesh and then just kind of like plopped it down. And I said, "Oh, that's pretty cool. I want to do something like that." So I said, and besides that, they were kind of these two guys were it was two attending urologists. They were just joking all the time. It was fun to be on the service, and I think that's pretty formative. And if you like the people that are in the specialty, then you get attracted to it.
Yeah.
As far as oncology, I wanted to do when I got to being a surgical resident, I really liked cardiac surgery and complicated operations, and I was thinking even about doing transplants, and then ultimately kind of felt like that was a pretty hard road for a urologist, maybe a dead end, but oncology offered a lot of promise. I was really lucky that I got to do the fellowship at Indiana, and I kind of consider the people that I learned from there to be like Jedi masters. I didn't feel like I learned. I feel like I learned 95% of the surgery that I learned how to do at Indiana.
Wow.
And they were like the Luke Skywalker and the Obi-Wan Kenobi, and we even had a Yoda that I learned from, and so I got to that's a lot of the reason why I got into oncology, and then came back to Colorado mostly because I had as you move around the country, I hate to say this, but there are certain personalities to different parts of the country, and as you move farther east, and probably this is generally true as you move towards the coast, the people become more rude. And so I really liked the personalities and the culture and the people I would get to deal with in Colorado. That's why I'm back, and that's why I've stayed so long.
Awesome. How about you?
So my story is a little bit different. When we were in medical school, I kind of liked surgery. I liked tying knots and all that stuff. And my wife realized my wife hated surgery. And she said if I was going to go into surgery, I could go by myself. That was it. So marriage was more important than training to do. But I also liked internal medicine a lot, and had a great experience. Dallas UT Southwestern and Dallas Parkland Hospital was just an amazing place to train, because it was in those days, and to some extent still, you could do everything and the attendings were kind of left you alone. So it was sort of a hospital run by the residents. And that year, my internship year, my mother developed breast cancer actually, and came and lived with us and had her surgery there. And I think that obviously influenced a little bit what I was doing. And then the second big influence for my career was the Vietnam War. So there was a program at the time at the National Institutes of Health that you could join. Essentially, you were in the public health service, but it was a research experience at the NIH, which was, you know, terrific. And you got to be in the lab and learn how to do research and write papers and all of that. And then during that time, it was sort of, okay, what are you going to do when you really grow up? And I had finished my internal medicine and had that 2 years of research experience, and they had just passed the Cancer Act. And a place called Dana-Farber Cancer Center in Boston had opened up. So I applied for fellowship there and got in. And it's kind of like Paul, I had some great mentors there. And then when we got around to saying, you know, where do we want to live? It was kind of the same experience Paul had. We had, you know, experienced the kind of harshness of in Boston and in Washington, D.C. So we kind of drew a line down the middle of the country, the Mississippi River, and said, we want to be west of there. And we both wanted to do academic medicine. So we sent out, you know, kind of cold call letters to all the medical schools. And Colorado had just started their medical oncology division. So a guy named Bill Robinson, who Paul knows, was the one person here, and he had a fellow with him, and that was sort of it. So Bill, you know, made a place for me, and I came out and joined the faculty. And then after I got started with my lab, which was working on a very arcane enzyme, and unfortunately never did have much success in developing that into something that was clinically meaningful. But I wanted to do clinical trials, and clinical trials are kind of the core business of a cancer center. And since Colorado didn't have a cancer center at the time, there were really very few things going on. So I wrote, again, cold call letters to 10 different companies. I mean, Pfizer and Bristol Myers and Eli Lilly and all that stuff. And one company, which was Abbott, wrote back and said, we have this drug we're working on called Abbott 43818. Why don't you come up to Chicago and we'll tell you about it? And long story short, that drug became a drug that we all use now called Lupron. That was sort of my entree into oncology and into GU oncology, because helping to develop that drug was how I got to know, you know, a lot about prostate cancer. Then we had, you know, different heads of the urology division came over time, and they were all fun to work with, and we developed, you know, kind of a urology oncology program that was, you know, 3 dimensions: radiation, surgery, and medicine. So it was a really fun career.
That's awesome. Now, when a patient comes to you, now, Dr. Glode, you're retired, is this correct?
I am retired, but I have a boutique clinic in Vail because somebody has to do it.
So right. Okay. All right. Well, then this will still apply.
Yeah, I see patients there three Fridays a month.
Okay, perfect. So when a patient comes to you and they have their symptoms, their scans, you know, whatever's going on, how do you go about determining the best plan? And I know it's individual, but are there specific factors that you take into consideration as you're kind of working with them to develop a plan for treatment?
I think maybe we should start with Paul, because most of the patients I see have already seen a urologist.
Okay.
And that's it's exactly where they are when I'm seeing, you know, many of them. If they've come in with metastatic disease, sometimes they haven't seen a urologist and maybe don't even need to. But a lot of times, even then, they need to get a biopsy to prove that they have cancer. But Paul can kind of outline how it is that a patient gets to him, and then maybe I can take it from how they get to me.
Okay.
Well, yeah. So as far as how they get to me, it depends on the kind of cancer they might have. It could start as an abnormal blood test that might, for instance, prostate cancer, they get a PSA checked and it's high. Their primary care doctor just checked that as a screening test to look for prostate cancer, and then they need a urologic referral. If it's bladder cancer, maybe they had blood in the urine. Mm-hmm. If they felt a lump in the testicle, maybe they show up with an ultrasound that's kind of frightening, and they got a kind of a frantic call from their primary care doctor. As far as how we make decisions about treatment, kind of depends on what it is. For instance, testicular cancer is pretty straightforward. They got a lump in the testicle. We're going to take that out and look at it under the microscope, maybe check some blood tests, get some scans, and we'll figure it out from there. If it's prostate cancer, it's a lot tougher. They have a lot of options, depending on what their values are, how bad their cancer is, some of their medical history, what their general health status. We kind of try to do a little bit more, substantially more complicated math to try to figure out, okay, well, what might be the best treatment for that guy? And then by the time that, for instance, a testis cancer patient that has, we do the testicle removal, it's cancer, we do a scan, and then we find metastases. Then I'm going to send that patient to somebody like Mike to talk about chemotherapy. Or if we find prostate cancer and it's spread to the bones, then we're going to, similarly, we're going to send that on to our medical oncology team. Okay. But yeah, it really depends on what they come in with. And then, a little bit, once we get more to the story, then we can kind of steer them the right direction in terms of the kind of treatment they need.
Okay. Do you have anything to add?
Yeah, I think the thing that Paul sort of touched on, but I'd emphasize, is that these days, for the most part, most cancer patients, including those with bladder, testis, and prostate, and kidney cancer, for example, it's generally a team effort. And usually there's some that don't need to see one or the other disciplines. Don't necessarily, like testis cancer rarely needs to talk to somebody in radiation oncology. But for the most part, all the cancers, whether it's colon cancer, lung cancer, breast cancer, the ones that we've been talking about, I think people are best cared for when there's a team of people involved, and that's what we have these tumor boards for. Just dealing with the prostate cancer patient that might see Paul and have a low-grade cancer that may not even need to be treated. A number of the patients I see actually come because, or even if they need to be treated, there's the choice of radiation or surgery, for example. And they'll come to see me because I don't have a dog in the fight. I can talk to them about the side effects and the pros and cons of going each direction and try and help them, make a decision. So I can add something to that thing. But and in the same way, some urologists do chemotherapy, but most of the time they don't. Having this team of people in breast cancer, it gets even more complicated because you have reconstruction experts and all of that sort of thing. So anyway, that's and now we have genetics. So getting a geneticist involved is very often a part of the whole game plan. And they talk to the families, and if they have an inheritable gene that needs to be looked at, it can change what their kids do for follow-up in terms of being careful about higher risk for breast cancer or prostate cancer or something like that. So the teams have grown over time.
Yeah. Since you brought up genetics, is there a certain gene that they're looking at for all three of those? Like, is it one, or are there different ones that are considered for bladder, prostate, and testicular? Is it a combination in terms of the heredity factor? How does that work?
Go ahead, Paul.
Yeah, so there's not really a single gene that links, that may put you at risk for all three of those cancers. And usually for the different types of cancers, there's going to be panels of genes. Now, if you go see a genetic counselor, they're not usually going to check for every single genetic mutation that they know of. What they're going to do is they're going to say, okay, you had kidney cancer, for instance. We're going to look at this panel of genes, which is 25 things. And the cost of those panels has come down incredibly.
Yeah.
And the access to genetics counselors is improved. But, the thing that's a discussion now is who should be starting the genetics counseling? Should we be doing that as oncologists? That's debatable. But at some point, they do negative test. We send everybody to a genetics counselor. Well, we also know that probably 10% of those patients are going to have a genetic abnormality. Right. Should we be doing a better job of trying to kind of weed out those patients first, like find the genetic abnormality and then send them on to the genetics counselors? I think that's probably the future of medicine, but there's still a lot of loose ends because you don't just want to willy-nilly get genetic testing. There's some implications with regard, you can't, health insurance isn't supposed to discriminate, but that doesn't mean that long-term care insurance and disability insurance and life insurance, there's implications there. How do you communicate, this news to not just the patient, but to their family members? There's a lot of reasons why a genetic counselor is pretty helpful.
Yeah.
And I think the challenge is also like when, different genes for different people at different times. So talking about what we were just talking about that's called sort of germline testing. But then, you get later into the course of a disease and somebody who has had metastatic disease for some period of time and the routine therapies aren't working. Now we can send off blood work and do what's called a liquid biopsy. And that gets really complicated. And the genetics counselors aren't at least in my experience, kind of well positioned to help with that. That's kind of unique to each patient's tumor. And many times, like the average prostate cancer patient has 20 mutations.
Wow.
And figuring out which one is important. And, and it's changing every day. And there's a whole concept of driver mutations, like you can have 10 mutations, but only one of them is really driving the cancer at any given time. It's just gotten extremely complex to know exactly how to do that. And probably in the future, there will be, like super genetics counselors to help us, because at least for me, and I try to keep up with it, but there are 3 or 4 companies now offering these liquid biopsies, and then they send you results, and it may have 3 or 4 different mutations, and there are clinical trials for each one. And, it's become very, very complex.
Oh, wow.
But the good news is for some mutations, there are specific drugs that are highly effective. And, probably lung cancer is the best example, but there's a 3% of people or something have a mutation called ALK, and there's a specific gene, and those people go into remission and all that kind of thing. So it's hard to keep up with, but I think, again, the team approach, you usually have a lot of people around you to help.
Yeah. We have a couple questions here. Let's see. What are the pros and cons of having a PSA test?
Go ahead. It was controversial, I think, until a couple of years ago, and we're starting to smooth out the language a bit here around this. We're supposed to do what's called shared decision making when we check a PSA, which means that we have a discussion with the patient. We try to explain what the ups and downs are and analyze their values, and then come to some sort of collaborative decision with the patient about what seems to be the most sensible to them. So the good parts of having a PSA test is you might end up finding a prostate cancer that's meaningful earlier. The downsides of the PSA test are you could find a prostate cancer that's never going to be relevant in your lifetime.
Interesting.
You could, you're still going to be anxious about that. You still might get it treated. You could be subject to extra testing and anxiety. So we just got a test that's abnormal. We just told you might have cancer. And then we maybe subject you to uncomfortable biopsy that includes a probe in your backside, and a risk of infection. Those infections occasionally can put people into intensive care units. Once that biopsy comes back, even if it's negative, I still can't conclusively say that you don't have cancer, which creates this sort of cycle of anxiety. We do MRIs, it's very costly, so it seems like there's a lot of downsides. But I think with a good provider to kind of help shepherd you through that, we can alleviate that anxiety. We can wisely use testing. We still see men die of prostate cancer, so I do think it's important that we identify it early. And in some men, we are making a big difference. And we can, even with careful shared decision making, even after a diagnosis of prostate cancer, like Mike said, some of these men we can just watch. Maybe they don't need to have their cancer treated; they could just have it carefully observed. So yeah, it's a complicated decision. There are some people out there that still don't believe that we should be doing PSA testing, but we have reasonably, to the extent they can be done well, reasonably well done studies to tell us that screening for prostate cancer can make a difference in affecting whether men die of prostate cancer or not. So yeah, it's not always, and we have to be, use discretion. If a 90-year-old guy comes in and he's feeling fine, we shouldn't be checking a PSA on him.
Right.
But if, we shouldn't neglect a guy that's 50 with a family history of prostate cancer that says, hey, I want to get a PSA test. We shouldn't be telling that guy he's foolish for wanting to do that. So, you do need to, have a good provider to deal with when you're talking about this.
Yeah.
And I think the key there is if your primary care doc knows you well. I mean, for example, prostate cancer turns out to be a slow disease. And unfortunately, we treat many men who may not have ever needed to be treated, even though they have what we think should be treated. A good example is a guy who's had, 2 heart attacks and is already on dialysis. That person, even if they're 50 years old, they probably prostate cancer, if we found it, would be irrelevant to their overall, life expectancy and all that sort of stuff. So where it gets challenging is the average 70-year-old guy has a couple of medical problems, and by the time they're 80, they have 3 medical problems, and then they're still concerned about should they be looking out for it. It's the same with colon cancer screening, for example. I mean, nowadays they say you got to stop when you're 75 unless you have polyps, and so it's challenging. It's a challenging area, and the shared decision making takes time. And so sitting down, that's what most patients talk to us about, saying, I really appreciate the amount of time you spent with us doing that. And the primary care doc who's got 20 more people waiting in the waiting room. Yeah. And, whoever he or she's working for has, exactly 12.5 minutes to spend with each patient. May not be able to do it justice.
Interesting. All right. Thank you. We have another question. Is there a particular age? This is still related to PSA. If someone were to get the PSA, is there a certain age where they should start? Or is that, again, a kind of a case by case, if there's a history in the family, if there's other health concerns, things like that?
Well, I can take it on first and let Paul chime in, and we'll ping pong. But so what I like to tell people is, if you have a strong family history, let's say your father had prostate cancer or your brother, that's a reason to start sooner. And in my case, I usually tell people to start at age 40 in that situation. And then we can look at the PSA and decide whether it's scary or not. But the PSA should be very, very low. And just to hang your hat on something, ideally, it should be less than 2 when you're 50, less than 3 when you're 60, less than 4 when you're 70. I mean, it's sort of that kind of number. It goes up in all men as they get older. But it's an age-dependent kind of thing. And then there's a lot of other things that go with it. For example, if you have BPH, urinary obstruction, Paul can talk about that. So there are other things that can go on that raise your PSA. So I'll flip it to Paul.
Okay.
Yeah, I just want to give a disclosure. I serve on the NCCN guideline panel for early detection of prostate cancer, but my views here that I express are not related to that. But yeah, the AUA says, start screening at 55. The NCCN would say start screening at 50 unless you're a high risk group, which would include a family history or African American race. So I agree with Mike. I got my first PSA checked, I think, at 37, and it was very low, much less than 1, and said, okay, well, I'm going to check it every 5 years until I'm 50, and then I might do it a little bit more frequently, but I don't have a family history.
Okay.
I was just more curious. I saw a guy who was 37 that had prostate cancer, and that probably inspired me. Probably inspired.
Always wakes you up.
Yeah. But yeah, you don't need to. One thing that the guidelines have done over time is to relax on how frequently we get it. So you don't necessarily need to do it every year if it's low. If it's high, you want to follow it a little bit more closely. Mike's right. If you're in your 40s and your PSA is anything more than probably 1, which seems pretty low still, but you are towards an end of the bell curve that you don't want to be on. If your PSA is over that number. Now, it doesn't necessarily mean you need to get frantic about it, but maybe every couple of years get it checked. And if it's 1.5 and then 2 in your late 40s, you probably ought to see a urologist to discuss what to do. Not necessarily get a biopsy, but just have a conversation, have a good examination just to make sure, because rarely, but we will a couple of times a year see men in their 40s that have bad prostate cancers, and or men in their early 50s that have metastatic prostate cancer, and we wish we would have caught those guys a couple of years earlier.
Yeah.
So, but it tapers off pretty quickly. Treatment past the age of 65 probably doesn't make at least a primary treatment of a low grade or not aggressive prostate cancer past the age of 65 probably doesn't make a lot of difference in the long run in terms of survival. Certainly in the 70s, you have to be very, very careful about screening asymptomatic men with PSA levels. It's not that we're neglecting our older men. It's just that the benefits of PSA screening become very, very minuscule at that point, and the risks become higher. So we usually will talk with them about, hey, look, your PSA's, it's been okay. In fact, my father, who was in his early 70s, had a PSA that was around 5. I said, don't get a biopsy, just watch it. It was stable for years and years and years. Ultimately, he needed, something else because he just had prostate enlargement and he needed to have that dealt with. But yeah, you don't always have to be aggressive about doing testing, once you're past about 70.
Okay, that's good.
The other thing to throw in is that same genetics issue. So now there's, half a dozen tests. If you have, let's say your PSA is 2.5 and you're 50, well, that's, it's a little too high and so forth. But the urologists all know, half a dozen tests. Some of them are just urine, some of them are blood. Tests that are more specific in terms of whether the risk for really having a significant prostate cancer. And those tests have all been developed in the last decade or so, and that they can be quite helpful in helping a patient decide whether to biopsy, for example.
Yeah, and the other high-risk group I didn't mention are people with known mutations that put them at risk for developing prostate cancer. So if you have if you're a male with the BRCA gene mutation in your family, you should be getting checked earlier. Or, those are ones where, yes, those are high-risk individuals. We should be screening them at younger ages.
Okay, so in other words, if a family member, even female, who has ovarian cancer or breast cancer, tested positive for the mutation, a man might get tested. If he has it, he might be at a higher risk for prostate cancer.
Absolutely.
Okay, interesting. All right, another question regarding genetics. Do genetics play a part in testicular cancer? How important are self-checks for men, even if you don't currently have cancer? Those are actually two different questions. One related to genetics, and one, how important are checks related to self-checks, I guess, related to testicular cancer?
Well, you're putting me out on a limb here because I can't remember. I know there are a couple of genetic abnormalities, but I don't know that they can be screened for. We do know that there is a family heritability of testicular cancer. So yes, if you have a family history of testis cancer Now we don't treat them any differently because the risks are still quite low.
Mm.
But if you had had a first degree relative with testis cancer, I can't remember what the increased risk is, but it's some increased risk that's just a couple percentage points higher than what you would experience otherwise.
Okay.
What was the second part of that?
The second part of it was how important are self-checks for men, even if you don't currently have cancer?
Well, so I tend to think that they're very important, but the reality is we don't know.
Yeah.
So I will say to men that have had testis cancer already, you have a 3% risk of developing cancer in your other testicle.
Mm-hmm.
And the best way to figure that out is if you feel it.
Mm-hmm.
I am not going to pick it up by getting an ultrasound every year. You're going to tell me that, hey, I got a lump in my testicle because you're examining it once a week. So I tell them, you still, in the shower once a week, pick a Monday, Sunday, whatever day of the week you want to do it, and examine your, do a good examination and let us know if there's an abnormality. Because an ultrasound is a painless, virtually harmless, painless and harmless test that we can get it, very quickly if we needed to.
Okay. Dr. Glode, do you have anything to add to that?
No, I don't. I mean, in general, testis cancer is, I guess it can run a little bit in families, but it's unlike breast and colon and lung and, well, not so much lung, but prostate and so forth. The genes and family history kinds of things haven't proven to be very helpful in testis cancer.
Interesting. Okay. To shift gears a little bit, with COVID, what changes have you guys seen in terms of maybe patients being reluctant to come in because they're worried about infection? And if there have been changes, how have you kind of pivoted in terms of online appointments or things like that?
So in my case, because I'm an old guy with a little bit of hypertension and probably a little bit of obesity, I've tried to be careful. Where I practice, the first outbreak was in Summit County or in Eagle County, or one of the first. So Vail Health was very aggressive about changing the way we saw patients and all that stuff. And within a very short time, in the first 1 or 2 weeks after we kind of realized what was going on, we went to 100% telemedicine.
Okay.
And then maybe in July, or may have been June even, we started seeing patients again. They had screening at the front desk, looking for fever and asking people questions and about had they been exposed or have they traveled, those kind of things. And then things were kind of back to normal until actually just last week or 10 days ago. And I personally said, I'm going to go back to 100% telemedicine now. And during the pandemic, I've seen 3 or 4 patients who've been infected. And they, had symptoms and got better. I've have a number of patients ask for the antibody test, and it's still a little bit controversial as to how effective that is and all that. And then lastly, I signed up for the Moderna trial myself.
Oh, interesting.
So it's nice to hear that it's effective, but I don't know whether I got placebo or the active vaccine. And it's kind of an interesting issue. I didn't have any side effects at all, so I think I probably got placebo. But in oncology, if you break the blinded code, and you now know who got drug A versus drug B, and if drug B was clearly superior to drug A, in oncology, we switch everybody over to drug B. And I don't think that the Moderna people have figured out exactly what they're going to do yet. Because obviously what they'd really like to do is have more people followed so that they can look at, okay, how many of these people who get infected, maybe it's still very effective at keeping you out of the hospital.
Right.
But they only have 100 cases, right? It was enough because 95 of the cases were in the placebo group, and only 5 were in the were in the vaccine group. So hopefully they'll sort this out. But it's kind of creating an ethical dilemma that's sort of interesting.
Interesting. Yeah. Dr. Moroney, anything to add on that?
No, I mean, the health screenings, the mask wearing, the telehealth, there's a lot of changes that we've made. Yes, people are avoiding
Yeah.
avoiding routine care.
Yeah.
I don't know when the other shoe is going to drop on that, but we'll be able to figure that out probably, unfortunately, in maybe several years.
Yeah.
I do think a hospital we've discovered there's so much mask wearing that I do think it's a pretty safe environment.
Yeah.
We have not had outbreaks in the hospital. So, I get it if you're a high risk, you want to avoid, you can do telehealth.
Mm-hmm.
But if you need an important scan or a critical blood test, that I wouldn't be petrified of a drive-by of going to the hospital to getting a CT scan. I mean,
Right.
You're going to just bump into 100% of people wearing masks. People, that aren't shaking your hands. They're not giving you stuff to handle. They're cleaning everything very well. And we just haven't seen outbreaks in the hospital. The community transmission, I think, is almost completely people going to other people's house and 10 people are there and somebody's sick and they don't know it and they have dinner and they're not wearing masks. That's how it's getting transmitted. It's not in healthcare settings, I don't think, because we've been living with over 100 patients with coronavirus, within 100 yards of just about 4,000 people, and we haven't had an outbreak. So, people have gotten sick, but it's, I think a lot of it's just they got it from home.
Right. Yeah, the thing I think it's a real social issue right now because we're coming up on Thanksgiving. There was a thing from Georgia Institute of Technology that was published today, and you can look up the counties, and then you can say, okay, I'm going to do Thanksgiving, and I'm going to have 10 people versus 15 people versus 20 people, et cetera, and so forth. Your chances of in Denver, I looked up Denver County, because I have a daughter who lives there and we're trying to decide what to do for Thanksgiving. Your chances of having somebody at a 10-person Thanksgiving in Denver right now who is infected and doesn't know it are 20%.
Wow.
So, it's a real serious issue right now. And what I've been telling people is, look, the vaccine is here. It's going to take 6 months to, roll out where everybody can get vaccinated. But it'd be great to be able to spend time with grandpa and grandma next year.
Yeah.
Just if you can cut it back. So my wife and I differ a little bit on this. I'm gonna go to the Thanksgiving thing, but I'm gonna be out on the deck the whole time. I'm gonna send somebody in with a mask on to load up a plate for me. But
exactly, you're gonna have a barrier around you and have to
I'm not gonna be around all those people. And
exactly,
it's just too dangerous. And we just have to hang on for another 6 to 8 months, and we'll get through this. So that's my advice: be as careful as you can, because it really is spiking right now.
Yeah. Once it's all over, so let's say 6 to 8 months, do you see telehealth continuing? Do you see that being, I guess, bigger than it was before COVID?
I think so.
Yeah, I hope so. This is I think been a big satisfier for patients. I had a patient that was at work. She's wearing a hard hat and she's at work and she's doing her visit with me. And, it's like, this is somebody that lives 3 hours away, she doesn't even need to leave work. She can just call me up and we can video conference for a couple of minutes, and she didn't need to spend, a whole day off of work to have a relatively simple conversation. There is, some peril out there. They're not letting much medical care happen across state lines, which is kind of a bummer for us, because we do, it's probably the patients that we probably are saving the most trouble with travel. We can't, we can do those visits. We can't charge for them. It's not all about charging, but if I did 100% of my patients that day from Wyoming, I basically worked for free that day.
Right.
So they need to kind of figure that out for to try to iron out some of those issues. They probably will lower the payments, but that's fair. I mean, we're not spending as much energy on these, and we can't examine people. We're not laying hands on them. So the visits are more convenient for us in some ways too. I mean, I can do them from home.
Right.
So, yeah, I think I hope it's, I don't think it'll go away completely. They'll probably change some rules around it, but
Yeah.
if they can iron out the interstate, if there's some cooperation between states with medical license and things like that, I think it'd be great.
Great. We have another question. Is an enlarged prostate something to worry about as far as cancer is concerned? And what can be done about an enlarged prostate?
Well, Chris, you're in my power alley. As far as prostate cancer, probably not. However, many men with an enlarged prostate also have an elevated PSA. So they end up getting subjected to some of these additional tests. Now, we can, MRIs have been very helpful, MRIs of the prostate, because now we can get a little bit better idea whether there's, first of all, is there a lesion in the prostate that we need to be worried about? Well, we can target biopsies to determine that. It also tells us about the condition of your bladder. So if the bladder muscle looks thick, then that's a problem. That could mean you have some urinary issues. Or if the prostate is really big, we can use that to kind of say, hey, look, you probably don't need to be too worried about prostate cancer. As far as what we do about prostate enlargement, that becomes a pretty long conversation. I mean, there's a lot of medicines and procedures and behavioral things that we can do to try to help manage that. There's a few situations where it's more urgent to do something if you have recurrent infections, or you're having lots of bleeding, or you have kidney failure because your prostate is blocking your urinary flow. In situations like that, we need to do things. But, in most cases, we can have a conversation about, okay, well, what can we do to try to, manage this in medical ways first, and then there's there's procedures that are done in the office now that are pretty straightforward. Wow. Yeah, that can help with the urinary symptoms of an enlarged prostate.
Okay. Dr. Glode, do you have anything to add?
No.
Okay. All right.
Urologists can deal with enlarged prostates.
There you go. Okay.
I know how to feel one.
All right. All right. Let's move on. Another topic we have is robotics. And one of the questions is, are robotic surgeries less invasive?
Yes. So a robotic is an additional tool to help what we call laparoscopic surgery.
Right.
Laparoscopic surgery, okay, let me kind of talk about what people generally construe as surgery. Let's say I need to go in and get your appendix out. We used to make a cut in the tummy that, if we were lucky, we could make it maybe 2 inches long. But if people had a really infected appendix, it could end up being 6 or 8 inches long to get that appendix out. Well, now we can get away with, and that the recovery from that is pretty uncomfortable. We've cutting muscle. You're going to have a lot of pain. You can end up in the hospital for days. Now we're doing surgery where we can make a few dime-sized incisions, insert skinny instruments and telescopes, and then attach a surgical robot to that, and have a lot of ability to do very complicated operations with a robot. And that's going to mean the recovery is faster. I did a prostatectomy the other day. What is today? I did it yesterday. He went home the same day. If you would have told me when I was a resident in urology that we would be sending patients home that had a radical prostatectomy the same day, I would have told you that you're nuts. But because we have ways of managing the pain now, and they generally are not too uncomfortable, that with the right education, and now, yes, it's considerably less invasive. But you can't do every operation that way. There's still some operations that are much more safely done by making a long incision and doing it the traditional way. I mean, there is a limit to that, but it is, I think has been really helpful in terms of helping patients recover more quickly and be able to avoid long recovers and long hospitalizations.
Amazing.
It's an interesting evolution too. When the robotic surgery started, and Paul got trained and started doing them 15 years ago, 20 years ago. Anyway, the hope was really that because the surgeon can see things much better, that there would be less, there would be a better cancer operation. Well, the things that people care about are, 1, being cured, 2, being continent with prostate, at least,
right.
and 3, having sexual function. And unfortunately, even though the surgeons can see things better, and the technology is really cool, those three things haven't changed very much with robots,
Hmm.
but the robot took over primarily for financial reasons. If if Hospital A had a robot and Hospital B didn't have one, oncologists and the patients, the general public perception is that the robot has to be better, right?
Well, right.
And we all hoped, in the beginning, we all hoped it would be, but reality was that Hospital B then needed to buy a robot in order to keep up with Hospital A, and the urologists at Hospital B had to train, and so end result is that now, what is it, 90% of prostate surgery is done robotically, Paul?
What?
Something like that.
Really?
Mhm.
Yeah.
Wow.
And
What
I
kind of
think
maybe
the
more than that.
recovery time is a little bit better and the pain's a little bit, but the guys who were doing open prostate surgery, 20 years ago got very, very good at it. And they would send people home the next day in general. And that's, Paul trained during both periods. He trained in open prostatectomies and then became a robot specialist like most of the urologists his age.
How much extra training did that involve in terms of making the shift to robotic surgery?
Yeah, I trained in the Wild West. So it was, it's, I hate to say this, but whenever you throw a new tool into medicine, there's some growing pains that happen whenever that. So there were early adopters. I would also say there was a lot of early challenges. We saw some pretty disastrous complications in people that,
Wow.
they'd been doing open radical prostatectomies for their whole career, and then now they got the robot, and they're trying to do an operation that's turns out to be pretty complicated with a lot of nuance, and they didn't do a great job. The people that we were learning from were probably also still in their learning curve, and so they were either reluctant to teach us, or they probably weren't as good at, we didn't have the teaching techniques really finessed at that time to really know how to now we do it a lot better. I think that most residents come out of a residency training program having done not just dozens, which was the case in, for me, but hundreds of robotic procedures. And we have robotic training pathways that are pretty scripted. And, I've gotten to be a better teacher over time. It used to be they kind of like did this and that was it. And now I've kind of like opened up the opportunities for some of my residents that are quite good to maybe be doing more complicated parts of the operation. But yeah, it was, it's hard to learn. I did extra training in my fellowship. I did not learn that at the University of Colorado. So that was something I also learned at Indiana and then brought back here. I was really the first urologist to be doing robotic surgery at the University of Colorado.
Wow. Interesting. We have another question. How long should the fatigue last after radiation? This person went through 44 treatments over 5 weeks, as well as Treglar for 3 months, and I'm going to butcher this name, Xtandi, Zandy. So the question is, how long should the fatigue last after radiation like that?
Well, if you just do radiation by itself, interestingly enough, there is fatigue associated with it, and it usually peaks, in the first month or two, like let's say the second month while you're still getting radiation, and then into the next month. If you add to that the hormone therapy that person was on, it clearly prolongs the fatigue. And most people don't start feeling better until their testosterone comes back. And when you get the drugs that he had, those drugs can knock your testosterone down. It depends on your age. If you're a 50-year-old guy, sometimes the recovery can be 3 to 6 months. If you're a 75-year-old guy, sometimes those two drugs, and if you've taken them for 6 months, it's different than if you've taken them for a year, and on it goes. So the fatigue is, goes away when your testosterone comes back, but your testosterone comes back, and it depends a little bit on luck and how old you are. And there's no doubt that not having testosterone contributes to fatigue, even without surgery or radiation. people on hormone depression really have a lot, it's a major part. And the way we counsel people to deal with it is to be very aggressive about their exercise program. The more you can exercise, the more you can fight it, even if you don't feel like exercising. I always tell patients, if you're an Olympic athlete and we put you on hormone therapy, there's no doubt you're going to, decline in your test, in your strength and have more fatigue. On the other hand, most of us aren't Olympic athletes. So if you kind of kick up your exercise program to twice what it always has been, or if you haven't been exercising at all, start really getting serious about, 3 hours of a week with cardio, half of it, and weightlifting the other half, you can fight the fatigue that way. So yeah, that's my answer for that.
Anything else, Dr. Moroney?
No, Mike's right on. It's probably the hormone therapy that's going to lengthen the fatigue the longest, but it's a necessary part of the treatment. So it needs to be tolerated. And I can't emphasize enough the importance of trying to get some regular exercise.
Yeah. Another question, how can Dr. Moroney be contacted? I don't know if you have a...
Yeah, I mean, I don't... I want to be careful about shameless plugs, but I'm at the University of Colorado Hospital, and you can find us online, and we do virtual health visits as well, and I try to be accommodating for people that live pretty far away. I'm happy to have conversations over the phone if that's what's required. Okay.
Well, our time is just about up, and the way I'd like to end is always to ask our guests if there's anything that you would share that I haven't asked you about. Whether it's about bladder cancer, testicular cancer, prostate cancer, surgery, recovery, suggestions, anything that I haven't asked you about that you might want to share with those who are watching.
Well, I'll start because I can't contain myself anymore. But I'm a big. I recognize that this year has been extraordinarily difficult for a lot of us, and I really want people to kind of attend to their mental health to the extent they can by getting plenty of sleep, trying to, avoid excessive, alcohol. I know that that's tough nowadays, so trying to eat healthy if they can. But, also, even though the people are getting really tired of Zoom calls and things like that, but try to reach out a little bit broader net. I think everybody's in the same boat. Anytime I kind of pick up the phone and talk with somebody I haven't talked to in a long time, I always feel a bit better about it afterwards. And with the days getting shorter, it's pretty hard right now. And with the threat of less social interaction and more isolation, I really want people to kind of focus on them. And so what I tell people, don't make 2020 the best year of your life. I mean, just try to survive it. But having those connections with people is really key.
Yes. Thank you.
Yeah, I think that's terrific advice, Paul. And the only other thing I would add, let me just reemphasize what you just said. I've had the opportunity to reach out to some people I hadn't talked to in years, old college roommates and that sort of stuff. And I think that can really be meaningful, provide some things that maybe you didn't take the time to do during your busy, when we were all able to go out to the restaurants and stuff. The other thing I would say, just because it's a cancer issue, is regardless of what kind of cancer you have, or, and I know that Epic takes, we take care, we have people from all over the map. It's really important to have a team that deals with that cancer. So, I think that there's a lot of expertise in the country. And, if you have a rare cancer, or even if you have let's just say colon cancer, because it's not, what Paul and I do, but if you have colon cancer, I want somebody who's taking care of colon cancer all the time. And it's, if you're in a big city or in a place near a big cancer center, you'll find a team of people that take care of colon cancer. And if you're in a small community, you might have, one medical oncologist and 2 surgeons or whatever. And that's fine, but you may want to get a second opinion from a team at one of the bigger places, because the oncology field is moving so fast. that I always tell my colleague up at Vail that I work with. He takes care of a lot of different kinds of cancer. I don't see how you keep up with it.
Yeah.
And he does a great job, and he's trained quite a bit extra in breast cancer, which is one of the major things that we take care of there. But yeah, so I think always feel free to get a second opinion from anybody, and make sure that that person is, spending a lot of time with that disease, because those are the people who keep up. I do nothing but prostate cancer, and I spend an hour a day going through emails and watching videos and reading literature and stuff like that. And a generalist doesn't have that kind of time. So that's my advice.
Excellent. Well, thank you both so much for your time, for sharing, and we really appreciate that we're here with us for today. So,
Thank you, Sunshine. This was a lot of fun. I really appreciate the opportunity.
oh, it was awesome. I learned so much from these, so I really appreciate both of you joining us.
Great job,
So-
Paul. It was good to see you again. And Paul and I talk about different patients all the time, but
I know
we
I'm gonna
haven't
have to.
seen each other for a while.
I'll Zoom you 4 days after Thanksgiving and see if you got sick or not. So,
Yeah, no. Well, we need to get a socially distanced beer or something sometime soon.
There you go.
Happy
Exactly. Well, thank you all, those of you who watched too and who contributed questions, and we'll be back in 2 weeks. So thank you very much. Everybody have a good night.
bye.
Epic Experience was founded after my oldest son, Michael, was diagnosed with testicular cancer in 2007. I wanted to offer up hope to other cancer survivors so people know they're not alone, so that they know they can get out and start living again. It just may look different than how it did before they had cancer.
Epic Experience is unique in the fact that we really pride ourselves on trying to take anyone and everyone that we can. It doesn't matter when you were diagnosed. If you've been diagnosed 5 years out, 10 years out, 20 years out, we don't put a timeline on it. We say that, you know what, if you've had cancer come into your life, we have a place for you.
Epic Experience. One word, it's epic. You have a chance to come up here and do some things that you've never probably done before.
This camp has taught me, why are you afraid? What's stopping you? I got out on the water in the pond here, and I'm I haven't done a headstand in a long time. And it's really difficult to do it on water. And I'm what am I afraid of?
At camp, it's about healing your soul and your spirit and living beyond that cancer diagnosis, having fun, being with people that understand, and really just embracing everything that life has to offer you.
They just said you were going to go to a camp, and I didn't even know where it was going to be. Got hauled up the mountain and